dense breast tissue and fatty tissue. Was that misconception of me that, oh, people who, have a lot of weight or they're heavy on the chest, more on the fatty side, they're highly likely to have breast cancer. Would you explain, from the doctor's point of view, how these two breasts are different and which one is highly likely to, give an environment of breast cancer to thrive or go unseen?
That's a good question. So, a simple way to put it, dense breasts, a breast that we would say in Swahili, they are standing up. They are not fallen soldiers. We're talking about breasts that are staying like you're 12 years old. Whereas, and they can go on even when you're 30, when you're 40, your breasts are firm. You've not had surgery, you've not had any lift, but your breasts are firm. So ideally, as you age, as you get to the age of 30, 40, what is expected is that they become less firm. In Kenya, they say they are the fallen soldiers, is the colloquial term that is used. So that is the expectation. But there are some women, their breasts are very taut. So even at their 40s, late 30s, their breasts are very firm and they're standing, and even after breastfeeding, they look like they're very young. And I think women love that. However, it's a risk factor because when we use the normal screening mechanism, like a mammogram, it can obscure. You might not see much because the density of it can hide a mass. So in such cases, when someone has dense breast, then we do screening that's a bit more. Because even if you do the clinical exam using your palm and the doctor goes and examines the whole breast, there are still things that may miss. You may miss a mass because the breasts are dense. So the fatty aspect, there are some breasts that are fatty, but they're not dense. And you can have a very full bust, but it's not dense. When you touch it, it doesn't feel hard, it's not firm. It is actually supple on touch. So for those who have dense breasts, then we know the risk of them developing breast cancer is on the higher side. Another risk factor, if you've had the benign, around the age of teenage, early 20s, there are some women who develop what are called fibroadenomas. These are non-cancerous breast lesions. So having those fibroadenomas is a risk factor. Has been shown that those who've had fibroadenomas in the past can be at a higher risk of getting breast cancer. So for such patients, when we see those masses, don't allow a doctor to take it out and not send it to the lab. It doesn't matter if you're 19. We have seen breast cancer in very early, in 19-year-olds, in 20-year-olds in Kenya. This is different from the rest of the world. For the rest of the world in the West, where Diana is, breast cancer is seen above the age of 40 for majority of the people. But in Kenya, our cancers start early. We need to do more research definitely to find out why. Why are we getting our cancers earlier? But if you notice a mass in the breast, if it is removed for whatever reason, kindly take it to the lab. Ensure the doctor takes it to the lab so that you know what it is. And if it's breast cancer, we can be able to treat it adequately in good time.
Wow. Do you know, when I was diagnosed with breast cancer on the left side, I had a fibroadenoma on the right side. And that was also one of the reasons that, made me stick on my decision to sweep off all the breasts from me. The misconception that all types of cancers, breast cancer and others, are only if there is history in a family, if it's genetic. I did not have that history in my family, and before that, I'm one of those people that if I saw someone has cancer, I was like, oh no, these people, I thought it just belongs to a certain people. It's in your family, you people are the ones who will get cancer. People who don't have it in their families, they will never get breast cancer or cancer. And then I come and find out the percentages, genetic, even very few, environmental, blah, blah, blah. Would you talk about this?
So that's a very, very good myth to discuss because most people will feel a lump and they'll do nothing about it because they'll say, there's no one with cancer. It can't be cancer. We don't have anyone with cancer in my family. So not having a family history of cancer does not mean you cannot get cancer. At least Diana has shared that she did not have a family history. Nobody in her family, at least I've met her mom, I've met her sisters. Nobody has history, even in her extended family. So it means that you could be the first person in your family. Actually, if you look at all breast cancers, only 10 to 15% is genetic. So that means we have a 90% chance that it will be you or it will be me, and I don't have a family history. So the genetic component is there, but it's not as strong as what we call sporadic, meaning it just happens without any reason that is genetic. Remember cells. How does cancer happen? Cells normally grow, divide, age, and die off. However, in that channel of being division, growing, an error can happen in one cell. And that cell goes crazy. So it starts dividing without dying off. Then it makes a group of other cells that are dividing and not dying off. And that is what we call a tumor. And when we look at that tumor, we can be able to see whether it has cancer or it doesn't have cancer. And majority of the time, it might have cancer within it or it might not have cancer. So also just having a lump is also not a direct thing to say you have cancer. There are lumps that do not have cancer. So not having a family history does not mean you cannot get cancer. Cancer is not painful. So if you notice something new in your breast, it is important for you to get it checked. And if it is cancer, then we begin treatment early. My motto is, if we know cancer today, we should have started treatment yesterday. That's just to say how fast we should start treatment. The other thing they say I've heard is, once you get a diagnosis of cancer, go get a second and a third opinion. That wastes time. If it is a reputable lab your sample has been taken to, and you have confirmed that you have cancer, let us start treatment immediately. This issue of I need to go see the best doctor in Nairobi, I need to travel see the best doctor here, I need to go here, wastes valuable time. It's important for us to hit the road when it's hot. So we've known there's cancer, we need to do something about it with immediate effect so that we control the disease. Remember, that crazy cell is still dividing. That group of abnormal cells are dividing. And the problem with cancer is like it likes to break off. So you have that tumor in one area, but a small piece breaks off, enters your blood. Then you find it in your lung, it moves, you find it in your brain, it can move to your liver. So the sooner we know about cancer, the better.
The sooner we know before they break. And then see, that's the other thing that whenever, and I normally call myself the factual breast cancer thriver. I am on facts, So somebody will be like, oh, they did not find it on my lymph node, so or whatever, so it's not spread. So I normally tell people there are two ways to spread. There's the lymphatic system and there's the blood. And that's why you need to eat well. And that's why you need to, if your doctor told you you need to have chemo, because they look at the chances of could these have already split and gotten into the blood, because don't think of cancer spreading only through the lymphatic system. Always know that the blood is also there. So they say that the lymphatic system is faster, but the blood is slow. That's why you'll find you went through treatment and 5 years down the line, 6 years, you're saying, but they said I was cancer free. And that time they tell you, now it is in your lungs. There is the one that fell into the blood. And so always going, and it will depend on where they go and implant. And you get that. Now, Dr. There's one I don't know if it's a misconception or not, but I've seen it a lot on my wall, and I've never even taken time to go and do my research on it. I've not. There's somebody who came and talked about root canal. He started asking, and yes, I blocked, because whenever I see myths and things that I don't see, I normally block those people, because I don't want to build that environment on the space where people are learning for people to catch some misconception. So this man was talking about, if you have ever had root canal, then you will have breast cancer. Have you heard of this?
That's a new myth. That's a new myth. Actually, I haven't seen a relationship between the breast and the teeth. What if it's about a dental procedure? What is true is that there are some cancers of the oropharynx that the first thing you notice, you will feel like a toothache. But it's not a toothache, it's a tumor beneath the tooth. And when you extract, then now you can have a tumor growing. So there are some people who've had tumors in the oral cavity that began near the jawline. and they felt a toothache. And that's what we call in medicine a red herring. It's not what really happened, but it's what told you there was a problem. You felt pain around that area. You thought it's the tooth. Maybe the tooth had a cavity. It was assumed to be the reason, but really, on the base of the jaw, there was something else happening. So there is no true relationship between a root canal and breast cancer, because even then the nerves around that area or the nodes around that area do not drain from the breast. So the nodes in the oral cavity really drain maybe to the neck and not to the breast. So there is no direct relationship between a dental procedure and now cancer of the breast. No, there's no relationship that's been proven to happen of the two.
To all the posts and saying, if you've had a root canal before, you are going to get breast cancer. And you see, that builds that fear in people, because people go for these procedures all the time, and I did not want the fear around the posts, you know. Now, I go into this other question. And it's something that is very delicate, Dr. Ari, and if you don't want to cover it, that's okay. When we went to the conference I just came from, I got people coming from India, and I had to engage them about the medical tourism that happens in India. And I've had conversations with a number of people, and some in the medical field in Kenya, and who believe together with me that sometimes, not all cases, but sometimes, there are doctors in other countries, maybe African countries, developing countries, who connive and work with doctors in India in cases where they know this is not going anywhere, but they still proceed to tell them, hey, there's nothing else we can do, but the people in India can do something. Would you advise, before people make a decision that now we are moving to India, what are the things that they can weigh on? The pros and the cons. What are the underlying things that can be used to advise their movement to India?
So that's a good question. And like you rightfully said, it's a dicey topic. It's a dicey topic because it borders on, I think for us to understand, we need to start with where did we come from? So if you look 20 years ago, we didn't have a lot of the services for cancer care. The cancer centers were few. They were mostly concentrated in Nairobi, and there were not so many oncologists. So 20 years ago, there was a challenge in terms of healthcare. The waiting times for radiotherapy 20 years ago were really long because it's only Kenyatta Hospital that had radiotherapy. So in that case, at that point in time, traveling to get services faster was something that was seen to be quite important, because for cancer care, if you're going to wait 6 months before you begin radiotherapy, then chances are by 6 months the disease will have really transformed to something else. So having said that, there was a time when we had a great need of these oncology services. And just like when there is need, there is definitely going to be market survey and people who will see how to tap into that market. So at that point, it was legal even to refer patients. Yeah. However, over time, there were more trainings of oncologists. So we had more oncologists in the country. And that meant they were spaced out. They were not all in Nairobi. Then we had decentralization of the radiotherapy centers. In Kenya, you can get radiotherapy in Garissa. You can get radiotherapy in Eldoret. You can get radiotherapy in Nakuru. You can get radiotherapy in Nairobi, 2 government centers and very many private centers. And you can also get radiotherapy in Mombasa. So that reduced the travel that people would have to travel. There is also the PET scan. If we looked 10 years ago, if we needed to stage using a PET scan, then it was not there in the country. So for us to adequately stage cancers that needed PET scan, then it was important or imperative to refer patients. And patients would go to India for that service. And it was very okay at the beginning because these services were not available. Even the government was very okay with doctors referring, especially because the services weren't there. However, when the services were availed, sometimes it's very sad when you see somebody travel all the way to get services that they could have gotten at home. Remember, traveling abroad means you have to go with a caregiver. You will have to be away from your business, away from your children. So there is a cost other than just the financial cost. There is the cost of your absence, the cost of people not able to visit you when you're going through the treatment. So for treatments that are available in Kenya, really, it makes a lot of sense to be treated here. One, you can access your doctor in terms of in case there's an emergency, they are a stone throw away or a phone call away. You're in the same time zone, you're around home, and even if they're not available, they can link you to someone they work with within the same county or country, and that makes it easy for access. NHIF also changed its rules because there was a time I think that was being abused, sending people to India. And now, if you're being sent for something that is available in Kenya, then the National Health Insurance has not been paying for that. They would advise you kindly just get treatment here. And I think also what you mentioned, sometimes false hope is sold, where you're told something can be done, whereas it's very clear that we're almost end of life. I lost a friend of mine who had pancreatic cancer stage 4, who was convinced that by a team in India that he would recover. And despite all our conversations, because he was really struggling to cling to hope, he was a young man, he went, but you see, the outcome wasn't very good. So sometimes it also borders on our integrity as doctors and us being honest, so that we are discussing facts as is, so that we help families not lose so much
Yes. And when
as
you
they
talk,
try and strive to get care.
yeah, they lose so much. You think of even young families with young kids and all these things, and it's training on them. And what I see
Yeah.
mostly here is at that point, they really emphasize on, family closeness and the closures and all that. But we lose on that a lot when we sell the false hope.
Yeah.
Now, there's for breast cancer, there's lobular kind and there's what do you call it, ductal type. I know the lump is mostly associated with the ductal carcinomas. What are the general symptoms that you would say that we can be watchful about? That if we see this is not going away so much, then we need to go check. But there are those who will say, but there's no lump. Okay, I see a dimple somewhere, but there's no lump, so there's nothing. What are those? I know the symptoms are very different for different women. There are some that I may have had that somebody did not have. But what are those that they need to look out for?
So that's a great question, and it's important for one to know what to look out for. So one is definitely your right foot and your left foot are not the same size. So pretty much the same thing about breasts, they're not the same size. But you need to know what is your normal. So we need to know what is normal for me. So is it my right breast that is bigger than my left? I need to know how my breasts look when I'm standing with my hands down and when I put my hands over my head, so that if I notice one breast is dragging down, or when I lift my hands, one is not moving, then I can know there's something holding the breast. If I look at my nipples, I need to know how my nipples look. So my nipples need to face out. If there's anything causing the nipple to go back in, then I need to know there is a problem and it needs to get checked. If I look at my breast and it looks like a tangerine with small holes, it's called in French peau d'orange. So it looks like so you just notice there's dimpling, small dimples, almost like pores that are quite enhanced, then I need to go to hospital. If I notice a change in shape, maybe it looks like there's maybe like a pebble on the breast, the outline is not smooth, then I need to go to get it checked. If I notice a discharge on my nipples, I need to get it checked. For some people, which is very rare, it may just present with discomfort in the breast. No mass, but discomfort. I have a friend of mine who just noticed she felt one breast was heavier than the other. No mass, but she was feeling a heaviness. When we did a scan is when now we noticed a small lesion within the breast. So it's important to know what is your normal. You need to know how your breasts feel and how they look. So every month it's good to be in front of a mirror with your hands down and look at how your breasts look. Are they sagging? Is one bigger than the other? Is there a dimple on the breast that is new? Is there any discharge that's coming out of the nipple? And then examine your breast. Am I feeling like there's a pebble or a hardness within the breast? And that needs to get checked. And that's not for women only, even for men.